Welcome to This Explainer. Today, we're doing a virtual curbside consult on something you literally see all the time, abnormal uterine bleeding, or AUB. We're stepping away from those dense textbooks today to take a super practical, case-based look at how to evaluate and manage these patients. I want you to picture your next shift. A 32-year-old patient walks into the ED reporting severe, heavy bleeding. Right away, you're faced with a major clinical dilemma. Exactly how much blood is too much, and is the underlying cause something structural, like a fibroid, or is it systemic, like a coagulopathy? Your initial approach here really dictates everything that follows.
So here's our roadmap for today's clinical rounds. We'll start with triage and terminology, then move on to history and red flags, dive into the PALM-COEIN framework, look at diagnostics, and finally wrap up with management strategies. Let's jump right in.
Section 1. Triage and Terminology, Modernizing the Clinical Vocabulary.
Our absolute first step in modernizing care is cleaning up how we talk about it. We are officially tossing out those vague, outdated terms like menorrhagia or dysfunctional uterine bleeding. Instead, FIGO really urges us to use standardized terminology: heavy menstrual bleeding, intermenstrual bleeding, and anovulatory bleeding. It just tells you exactly what is happening. No translation needed.
Now, when we talk about heavy menstrual bleeding, 80 milliliters per cycle is the objective threshold for abnormal volume. But let's be real for a second. Patient self-reporting is highly subjective and honestly often inaccurate. You can't exactly measure 80 milliliters in the clinic, right? So instead, we rely on indirect indicators. Think about things like passing blood clots larger than an inch, bleeding through clothes, or having to wake up to change pads at night. Basically, if it interferes with their physical, emotional, or material quality of life, boom, it's heavy menstrual bleeding. Okay, before doing any deep diagnostic detective work, you absolutely must follow a rapid triage protocol. Step 1, check hemodynamics. If they're tachycardic or hypotensive, stop right there. They need emergency stabilization. Step 2, exclude pregnancy. A simple HCG is literally mandatory for all reproductive age patients. And step 3, classify the pattern. Is it irregular, heavy, or intramenstrual? Figuring this out sets the stage for your entire algorithm.
Section 2. History and red flags, the detective work. Once your patient is stable, taking a targeted history is like having a cheat sheet. It often reveals the diagnosis before you've even ordered a single lab test, but you really have to know your red flags. Hemodynamic instability or a positive HCG, those require acute management. Keep an eye out for bleeding disorders too, like easy bruising. Oh, and this is absolutely crucial. Even a single episode of new-onset postmenopausal bleeding is a massive red flag. We're talking immediate investigation for malignancy. All right, let's look at our first clinical archetype, the adolescent patient. During the first 1 to 2 years after menarche, the absolute most common cause of abnormal bleeding is anovulatory cycles. Why? Well, it's because the hypothalamic pituitary ovarian, or HPO axis, is still kind of immature. That mid-cycle LH surge doesn't happen, estrogen goes completely unopposed, and eventually the endometrium just breaks down and bleeds heavily. But keep in mind, an immature HPO axis is strictly a diagnosis of exclusion. And here is exactly why we have to rule out other things first. If an adolescent presents with extremely heavy bleeding right from their very first period, especially if it's severe enough to require hospitalization or a blood transfusion, you must immediately suspect a bleeding disorder. Honestly, up to 20 to 60% of adolescents seen in multidisciplinary clinics for heavy menstrual bleeding actually have an underlying coagulopathy. And the most common culprit? Von Willebrand disease.
Section 3. The PALM-COEIN Framework, Classifying the Etiology.
This framework right here is a real game changer. It fundamentally organizes your clinical thinking into 2 distinct groups. On the left, we have the PALM group. These are your physical, structural causes that you can actually see on imaging or a biopsy: polyps, adenomyosis, leiomyomas, and malignancy. Then over on the right, you have the COEIN group. These are the non-structural systemic causes: coagulopathy, ovulatory dysfunction, endometrial issues, iatrogenic causes, and things not yet classified.
Now, check out how the PALM-COEIN framework shifts dramatically depending on the patient's age. For adolescent patients, your differential is going to lean heavily toward the right side of the chart, specifically O for ovulatory dysfunction and C for coagulopathy. But fast forward to adult patients, and those structural issues on the left, like polyps, adenomyosis, and leiomyomas, become way more prevalent. It's like a sliding scale based on reproductive stage.
Section 4. Diagnostics, labs to imaging, from blood work to ultrasound.
Okay, so you've taken a fantastic history and you suspect a specific category. Now, how do we actually confirm it? Well, here is your targeted lab panel. A CBC and an HCG, totally non-negotiable. TSH and prolactin are great for evaluating ovulatory dysfunction. But listen up, because here is a massive clinical pearl when it comes to coagulopathies. You literally must draw a von Willebrand panel before you give the patient any exogenous estrogen to stop the bleeding. If you don't, the estrogen will artificially inflate their von Willebrand factor, giving you a falsely normal result. You definitely don't want that.
When it's time for imaging, pelvic ultrasound is universally going to be your first-line choice. It is absolutely perfect for evaluating those structural lesions from the palm side of our framework. Now, for adults, a transvaginal ultrasound gives you the best, most detailed look at the endometrium. However, for our adolescent patients, or honestly anyone who just can't tolerate a vaginal probe, a transabdominal ultrasound is a totally appropriate and much more comfortable alternative that still gives you excellent clinical data.
We also really need to nail down exactly when an endometrial biopsy is required to rule out hyperplasia or malignancy. The guidelines here are pretty strict. Step 1, you absolutely must biopsy any patient over the age of 45 who comes in with abnormal bleeding, period. Step 2, for patients under 45, you biopsy if the bleeding was persistent and they have a history of unopposed estrogen exposure. This is actually super common in patients with obesity or chronic ovulatory dysfunction, like PCOS.
Section 5. Management strategies, medical, surgical, and fertility considerations.
All right, diagnostics are done. Now let's talk treatment efficacy. If we look at the high-end reduction of menstrual blood loss, NSAIDs can reduce bleeding by about 40 to 50%. Not bad. Combination oral contraceptives can get you up to a 69% reduction, but check this out. The 52 milligram levonorgestrel IUD boasts up to a massive 95% reduction. That completely blows oral medications out of the water, making it an incredibly powerful first-line therapy.
But of course, we don't treat patients in a vacuum. A patient's desire for future fertility is going to drastically alter your treatment plan. If someone is trying to conceive soon, you're going to lean on options like tranexamic acid, which they only take during their period, or maybe a targeted surgical myomectomy if they have fibroids. On the flip side, if childbearing is complete, you suddenly have a much wider array of highly effective options, ranging from the LNG IUD all the way to definitive surgical interventions, like an endometrial ablation or a hysterectomy.
Hold on, though. Before you write that prescription for an estrogen-containing contraceptive, you have got to screen for absolute contraindications. Do not give estrogen to patients with a history of venous thromboembolism or stroke. Just don't do it. You also want to avoid it in anyone with migraines with aura, patients over 35 who smoke heavily, or those with multiple cardiovascular risk factors. For these folks, you've got to default to your progestin-only therapies, like the levonorgestrel IUD or depot injections, or stick to non-hormonal options like tranexamic acid.
Wow, and just like that, we've reached the end of our clinical rounds on AUB. We've officially tossed out that outdated terminology, embraced the PALM-COEIN system, zeroed in on the red flags, and navigated some pretty nuanced diagnostic and management pathways. So my final question to you is this: how are you going to apply this modernized, highly structured approach to the very next patient you see? Thanks so much for joining me on this explainer today. I really hope this empowers you to provide even sharper, more effective care out there.